Hello, and welcome to the Sarah Clinical Education Neuroscience Podcast. I'm your host, Tadani. Today's episode, Breaking the Therapeutic Ceiling, Emerging Treatments for Schizophrenia Care, features Dr. Leslie Citrome, who will discuss how advances in our understanding of schizophrenia and neurobiology are opening a door to novel treatment approaches beyond traditional dopamine receptor blockade. We'll hear about emerging clinical evidence, including new muscarinic-targeted therapies, and what these developments may mean for treatment selection, safety, tolerability, and patient care. This episode is part of a larger educational program, Breaking the Therapeutic Ceiling in Schizophrenia Care. For more information about Dr. Leslie Citrome, along with a link to the full program, please visit the show notes for this episode. Now let's get started and hear what Dr. Citrome has to say about this evolving area of schizophrenia treatment.
Well, thanks very much for the introduction, and thank you everybody for joining us today. We're going to talk about something that actually is kind of new, kind of interesting, and kind of revolutionary. For years, we've been treating schizophrenia by blocking dopamine receptors in the striatum, and we think that there's too much dopamine in the striatum, that part of the brain that produces hallucinations and delusions. So for years, we've been blocking those dopamine receptors that exist there, and by blocking the dopamine receptors, we manage the hallucinations and delusions because there's just too much dopamine. Well, we're going to learn about differentiating dopaminergic and muscarinic mechanisms of action of therapies and explain a bit more about what we have to do in terms of unmet needs in people with schizophrenia. We'll evaluate the clinical evidence that supports other ways of treating schizophrenia. We're going to look at efficacy, safety, and some limitations of the information we have so far. And we're going to think about strategies to integrate these new novel approaches into treatment plans and figure out how to best offer it and how to manage different side effects. So what's old? What's old is the dopamine hypothesis of schizophrenia. And the early models that we've had for years has been that we have excess dopaminergic activity in the mesolimbic pathway. That's the pathway going from the ventral tegmental area to the ventral striatum. And that's supported by models using psychostimulants like amphetamines that produce psychotic-like symptoms when administered to people, as well as antipsychotic efficacy being correlated with D2 receptor antagonism. Animal models show mesolimbic hyperactivity induce psychosis-like behavior. So we have an animal model for psychosis. And we also have recognized hypoactivity in the mesocortical pathway. So ventral tegmental area with connections to the cortex. That's old. It explains a lot of things, but not everything. And it turns out that is incorrect in terms of what applies to people. Humans are different from rodents. And yes, it's true. Humans are different from rodents. And the new dopamine pathway story involves a different part of the deeper structures in the brain and is not the ventral tegmental area in people. It's part of the substantia nigra, which is very confusing to people because the substantia nigra has been always associated with a pathway for the control of motor movements, not psychosis. However, it appears that part of the substantia nigra in human beings goes and projects to a part of the striatum called the associative striatum, and excess dopaminergic activity there explains psychosis in people. So we can refine the dopamine hypothesis looking at the pathways in people, which turns out to be somewhat different than rodents. And in particular, we still see this increased dopaminergic activity, which explains psychosis. That's the important part. Too much dopamine leads to hallucinations and delusions. Now, it's not really important for our story to know exactly where this pathway is located, simply to remind ourselves too much dopamine in the striatum produces hallucinations and delusions. The problems of dopaminergic pathway issues remain with us, and I should go over this in a bit more detail. The mesocortical pathway I mentioned earlier from what we thought was the ventral tegmental area in the midbrain to the frontal cortex. And that pathway will explain issues in people with schizophrenia in terms of negative symptoms, cognitive impairment, and depression. The mesolimbic pathway we originally thought from the ventral tegmental area and goes to the ventral striatum, olfactory tubercle, parts of the limbic system, that has explained in the past positive symptoms of schizophrenia. But now we have a better recognition that this really explains a bit about negative symptoms only. And the key pathway that we now appreciate is nigrostriatal pathway number 1, going from the substantia nigra, special part of it, and innervates the associative striatum. So that's the refinement of the model. Nigrostriatal pathway 2 is still there, goes from the substantia nigra and innervates the sensory motor striatum or dorsal striatum, and blocking dopamine receptors there causes no end of problems motorically. The tuberoinfundibular hypothalamic pathway explains hyperprolactinemia. But there's more, really, unfortunately. There's an association between other receptor blockade and tolerability. And our second generation antipsychotics typically have affinity to all sorts of other receptors. Alpha adrenergic receptors, which may lead to postural hypotension, increased blood pressure, histaminergic receptors, which blockade can lead to sedation, weight gain. Muscarinic pathways, blockade there leads to cognitive impairment. And 5-HT2C antagonism, those serotonin receptors are responsible for control of appetite. And so blockade of those receptors can increase appetite. So along with the dopamine D2 blockade of our antipsychotics, we have a whole assortment of other receptor blockade and consequentially tolerability issues. The big problem is D2 antagonists. Our antipsychotics are not selective. Although there's too much dopamine in the associative striatum causing psychotic symptoms, and that we can block D2 receptors and decrease hallucinations and delusions, it doesn't stop there. Blocking postsynaptic dopamine D2 receptors where we want to is accompanied by D2 blockade where we don't want to, causing motor adverse events, drug-induced Parkinsonism, akathisia, dystonia, ultimately tardive dyskinesia. And elevation in prolactin can also occur by blocking dopamine D2 receptors elsewhere in the hypothalamic pituitary pathway. Another way to treat psychosis is perhaps decreasing the amount of dopamine released in the first place. Do it presynaptically. And if we can do that selectively, only in those circuits that modulate dopamine where we want to, maybe we can treat psychosis without causing all sorts of other collateral damage. And maybe muscarinic receptors will fit the bill here. And that's the story we'll talk about today. Presynaptic dopamine dysregulation needs to be addressed. So one way is just decreasing the amount of dopamine that's either synthesized or released, and intervening upstream of the dopamine D2 receptor is a strategy that can possibly work. But up to now, we really haven't had anything in the clinic that we can use to treat psychosis that works that way. And we've been stuck with dopamine receptor blockade. There's other ways, though. Muscarinic receptors can be targeted, and we'll talk about a specific agent called xanomeline, and it combined with trospium can be used to treat people with schizophrenia. The xanomeline targets muscarinic M1 and M4 receptors. It modulates dopaminergic circuits. I'm going to explain this in much more detail in a few moments. There have been other approaches to address the release and action of dopamine. So releasing dopamine can be modulated by glutamate. Yep, glutamate's involved in this story here. And it's thought that one model of schizophrenia has been the NMDA receptor hypofunction hypothesis, leading to dopamine dysregulation. I'll explain that as well. Trace amine receptor agonists have been explored as a potential treatment of schizophrenia by regulating dopamine release. We've had a drug candidate there. Unfortunately, it failed the initial trials, but it's still going to be evaluated as we speak, still going on in terms of clinical trials. And there's also another way of addressing these NMDA receptors. So these glutamate receptors are very complicated. They need to be activated, of course, by glutamate, an excitatory neurotransmitter, but also by a coagonist called glycine. So glycine needs to be there as well. And if we can increase the amount of glycine at the synapse, well, maybe these NMDA receptors would work better. That strategy has been used to address negative symptoms and cognitive deficits, but so far we have had no successful agent reaching the point of FDA approval. So let's talk about this glutamate hypofunction and how it can explain some symptoms of schizophrenia that we see. So NMDA receptors are very complex. They are really present in many places in the brain, and they're activated by glutamate, the brain's most commonly encountered excitatory neurotransmitter. NMDA receptors don't work alone. You need other glutamate receptors called AMPA or kainate. The important point is, in people with schizophrenia, there may be hypofunctioning of this NMDA receptor. We know that we can develop mice models that explain this quite nicely. Transgenic mice with reduced NMDA receptor expression exhibit hyperactivity and reduced social interactions. So that's a model of psychosis. And NMDA receptor antagonists can induce cognitive disruption. And in humans, NMDA antagonists at high amounts can induce hallucinations and delusions. NMDA antagonists also induce cognitive deficits. That we know in people and non-human primates. But in the end, NMDA receptors are complicated. So regulating them directly is complicated. And maybe there's another way. The other way is addressing that interneuron. So you know that glutamatergic neurons give a positive signal to wherever it connects to. It increases activity in circuits, and it's held back by GABA. GABA is the brain's ubiquitous inhibitory neurotransmitter, and GABA interneurons are also all over the brain, and they control the glutamate neurons. So GABA puts the brakes on glutamate. And in people with schizophrenia, there is insufficient excitation of this GABA interneuron. So if this GABA interneuron isn't working because the NMDA receptor on it isn't working, then you're going to have a problem. So this is actually an interesting story here. You need that negative signal to stop glutamate. However, if there's insufficient glutamate, you're not going to be able to stop excessive glutamate later down on the chain. And excessive glutamate ultimately will result in excess dopamine and ultimately result in hallucinations and delusions. So this NMDA receptor on the GABA interneuron is really important. When activated, it will excite the GABA interneuron, allowing it to inhibit glutamatergic neurons next down the chain. So it's a regulatory process here, and you really need that GABA interneuron to put the brakes on things. However, it doesn't happen in people with schizophrenia, and the relevant glutamatergic neuron down the chain is disinhibited. Too much dopamine is ultimately released in the circuit responsible for psychosis. So I drew a little picture of this GABA interneuron. He's supine in bed, thermometer in his mouth, ice pack on his head. He's sick. Can we make him better? So yes, we can. Muscarinic agonism can treat this sick GABA interneuron. So how does it do that? Muscarinic M1 receptors exist on the GABA interneuron. They also excite the GABA interneuron. So a fix here for NMDA receptor hypofunction is to increase the activity of this muscarinic M1 receptor located on that very same GABA interneuron. And when we activate that M1 receptor, it will excite the GABA interneuron, allowing it to inhibit glutamate. And that's good because we want to decrease glutamatergic activity so that we decrease dopaminergic activity. We want less dopamine released in the striatum that's responsible for hallucinations and delusions. We can call this M1 chicken soup for the brain for people with schizophrenia to fix their GABA interneurons. So muscarinic agonism is actually an old story. In 1957, aricoline was found to actually modulate these symptoms we see in rats that are a model of schizophrenia. And we've also noted in the 1950s, if you look back in the history books, that aricoline can actually treat psychosis. However, they measured it by lucid intervals, and can you have conversations with patients with schizophrenia for longer than a few seconds? If you can have more lucid intervals, you're actually treating psychosis. And you can do that with arecholine injected under the skin. So arecholine is a muscarinic agonist. And by the way, arecholine is found in betel nuts. And in some cultures, chewing betel nuts is pretty common. That may be a treatment for people who are psychotic. In 1992, xanomeline was synthesized. It's a relative of arecholine, and it was synthesized with the purpose of improving cognition in people with Alzheimer's dementia. Xanomeline has no direct D2 receptor blocking activity. So in 1997, this study in people with Alzheimer's disease, double-blind, placebo-controlled xanomeline, this study revealed that yes, cognition improved. And surprise, surprise, it seemed to also improve psychotic symptoms associated with Alzheimer's dementia. Well, this got to be very interesting, and further developments revealed that xanomeline actually will reverse some of the issues found with mice when we knock out their M1 and M4 receptors, and that we have this dysregulation in these mice that look like psychosis, and we can address some deficiency in M1, M4 receptor activity with agonists that appear to reverse the psychosis that we induce. So this is interesting, supported by animal models. A little bit more about muscarinic receptors that you need to know about. There are excitatory muscarinic receptors and inhibitory muscarinic receptors. The excitatory muscarinic receptors are M1, M3, M5. You'll notice that they're odd numbers. Inhibitory muscarinic receptors are M2 and M4. They're even numbers. Now, these muscarinic receptors are located throughout the body, in the brain and in the periphery. They operate by G protein cascades. So there's a whole bunch of events that occurs when these receptors are activated. And it helps us control neuronal excitability, learning and memory, but also cardiac function and smooth muscle contraction and exocrine gland secretion or saliva, as well as insulin. Now, the excitatory muscarinic receptors, M1, M3, M5, are postsynaptic, and they're activated by agonists or positive allosteric modulators that actually work by increasing activity without going to the actual site where the acetylcholine goes, but another site on that receptor, and that seems to work as well. The even-numbered muscarinic receptors are presynaptic. What does that mean? It means they're inhibitory. So presynaptic receptors, watch out for them. They are the important link in regulation in terms of decreasing the amount of neurotransmitter that's ultimately released. Muscarinic receptors, M2, M4 presynaptically, will dial things down. The excitatory muscarinic receptors postsynaptically will ramp things up. And we can target those receptors as well. So let's go through some circuits. There's the top-down story of the control of hallucinations and delusions. How does that happen? Muscarinic M1 receptors are excitatory, right? They exist on GABA interneurons, right? We talked about that. GABA interneurons control glutamate neurons. If you don't have inhibition of the glutamate neuron, you're going to have too much glutamate being released, resulting in excitation in the ventral tegmental area, or where dopamine neurons live, and you're going to have more dopamine neurotransmission if you excite those dopamine neurons. We don't want to do that. We want to put the brakes on that glutamatergic neuron that connects to the dopaminergic neuron. We can do that by increasing the activity of this GABA interneuron in the cortex. M1 receptors live on that GABA interneuron, and by agonizing or exciting that M1 receptor, we make that GABA interneuron work better. It inhibits glutamate, that glutamatergic neuron, to the point that it doesn't excessively excite the dopaminergic neuron that it connects to. You'll have less dopamine released in that part of the striatum that explains psychosis. So this downstream effect does the job. Instead of blocking those D2 receptors in the striatum, we just reduce the amount of dopamine that is released in the first place. That's the top-down story, because it starts in the cortex with GABA interneurons. But there's also the bottom up involving autoreceptors. So just as a reminder, autoreceptors are receptors on nerve cells that respond to the same neurotransmitters released by that cell. So it's a negative feedback loop. If you have too much of that neurotransmitter, it bounces back to that presynaptic neuron and shuts down or decreases the amount of neurotransmitter being released. We have many examples of this in medicine, and there's a recent example in the treatment of agitation associated with schizophrenia or bipolar disorder. Well, actually, an old drug reformulated called dexmedetomidine, which actually decreases norepinephrine release in the locus ceruleus. Decreasing norepinephrine release there reduces agitation simply by agonizing the right autoreceptor. So we can do that with muscarinic receptors, the even-numbered muscarinic receptors, and particularly M4. Now, in the hindbrain exists a nucleus of acetylcholine cells. It's in the lateral dorsal tegmentum. We abbreviate it as LDT. The LDT controls ultimately the part of the brain that projects to the striatum. So that part of the brain, we will call it the ventral tegmental area. If you can control the VTA, you can control the amount of dopamine that is being released in the striatum. And you can do that not only top down, but bottom up. So this LDT is a nucleus of cells that release acetylcholine. And acetylcholine is excitatory. And when connected to the VTA, which is where dopamine neurons live, you're going to increase the activity of these dopamine neurons, and you're going to influence the amount of dopamine that's released in the striatum. So maybe we can slow things down. Maybe we can inhibit that circuit, the LDT to the VTA, that acetylcholine release can be decreased, hence decreasing the excitation of the dopaminergic neuron that goes to the striatum. And less dopamine there means less hallucinations or delusions. So that's the bottom-up approach. M1 top-down. Starts in the cortex with the GABA interneurons. The M1 receptor lives there, and it connects to the glutamate neuron, which is excitatory, which connects to the VTA, which is our dopamine neurons, which goes to the striatum. In a healthy brain, this works well, and you have good control of the amount of dopamine that's released in the striatum, and you don't have hallucinations and delusions. The bottom-up circuit is also well regulated in a healthy brain. So in the hindbrain is that LDT, lateral dorsal tegmentum. That's a nucleus of acetylcholine's neurons, and that connects to the VTA, where the dopaminergic neurons are, which of course connects to the striatum. This all works well. That M4 receptor works fine, and you have a good amount of dopamine, not too much, not too little, and you have a healthy brain. Unfortunately, in a psychotic brain, those GABA interneurons are sick. You have too much glutamate being released. Ultimately, why? Because you're not putting the brakes on that glutamate neuron. And that glutamate neuron works excessively, and you have too much excitation in the VTA where the dopaminergic neurons live, and hence too much dopamine being released in the striatum, and you have psychosis. Bottom up, similar story here. You don't control the release of acetylcholine. You have too much being released and exciting the VTA dopaminergic neurons. You have too much excitement there, too much dopamine released ultimately in the striatum, because that M4 receptor isn't adequately inhibiting this pathway. So that's in psychotic brain. What do we do with dopamine receptor blocking agents? Well, we create a shield that prevents the excitation of that neuron by blocking those dopamine receptors that exist in the striatum in those neurons there. We control the signaling not by reducing dopamine release, but by blocking dopamine action with the DRBA shield. So both top-down, bottom-up pathways are controlled not directly, but really managed by blocking the dopamine receptors finally in the striatum. So that's one way of doing it. We've been doing it for years. It helps psychosis, but there's got to be a better way. And that better way is M1, M4 agonism, because they can selectively target those circuits that explain psychosis. GABA interneurons can be excited by M1 receptor agonism, which results in inhibition of the glutamatergic neuron. Remember, GABA is inhibitory, increase inhibitory tone, you're going to decrease ultimately glutamate excitation. The glutamatergic neuron releases less glutamate, resulting in less excitation of the dopaminergic neuron, leading to less dopamine being released in the striatum. Bottom up, we can increase the activity of the M4 autoreceptor, dial down that LDT release of acetylcholine, thus dialing down the dopaminergic neuron, thus dialing down the amount of dopamine released in the striatum. So it top down, bottom up, controlled selectively by muscarinic agonism, M1, M4. Well, that's the explanation we think what's going on. And that's the heavy lifting here in understanding this new approach to addressing schizophrenia. Xanomeline fits the bill here in terms of M1, M4 agonism. It goes to, of course, all muscarinic receptors, but functionally, it works more at M1, M4 receptors in terms of agonism. And we know that it kind of worked in Alzheimer's dementia and improving their cognition and surprise their psychosis. And it was thought that, hey, maybe we can use this for schizophrenia. And a pilot study was done in 2008. It was reported, xanomeline, double-blind, placebo-controlled, 4-week trial. And it resulted in a decrease in psychosis for those randomized to xanomeline, much more so than a decrease in psychosis observed with placebo. Well, BPRS, Brief Psychiatric Rating Scale, showed improvement for those on xanomeline superior to that seen with placebo. And moreover, cognition also seemed to improve. So what's the catch? Well, the catch was the tolerability. And the problem here is excessive GI side effects, because muscarinic agonism is going to increase GI activity, and vomiting occurred in 60% of the patients randomized as xanomeline. So that's a deal breaker when developing a drug. 60% of patients had experienced vomiting. So what can we do about that? Well, how can we mitigate the procholinergic activity of xanomeline? Perhaps by blocking muscarinic receptors in the periphery that otherwise xanomeline excites too much. How do we do that? Well, we find an anticholinergic that doesn't go into the brain. We find an anticholinergic that just will be distributed in the periphery. And trospium fits the bill here. Trospium is an anticholinergic agent, doesn't cross the blood-brain barrier, has no central effects, but has peripheral effects. It manages excessive muscarinic agonism, or at least addresses some of that. Now, this drug trospium has been approved in the U.S. for more than 20 years for overactive bladder. It's been around since the 1970s, and it actually will serve as an antidote, so to speak, to xanomeline's activity in the periphery. Now, does this actually work, xanomeline-trospium combination? Actually, it does. It was studied in people with schizophrenia, and in 3 studies that recruited patients with acute exacerbations of schizophrenia, patients were randomized, either receive xanomeline-trospium or placebo, and observed for 5 weeks. And it was found that psychotic symptoms decreased more with xanomeline-trospium than with placebo. Not only that, a whole lot more. So the effect size is large. What do I mean by effect size? Basically, effect size is the way to look at a clinical trial and see if it's clinically relevant or not. That p-value won't tell you anything about the importance of the clinical trial result. All it tells you that it's probably true because it's statistically significant and not due to chance. How do we know if it's important? The size of the treatment effect has to be important. The point differences needs to be relatively large. And we can express that in a standardized way by looking at the point change difference and translating that into standard deviation units. Now, this is how it's done statistically. It's called the Cohen's d, standardized mean difference. So we can look at the point change in the results of the positive and negative syndrome scale total score, and we can take a look to see how large it is in a standardized way. And a Cohen's d of 1 would mean 1 standard deviation difference, which would be huge. 0.2 standard deviations would be small, 0.5 in the middle. We can also calculate number needed to treat. How many patients needed to be randomized to the drug of interest compared to placebo before expecting one additional patient to be a responder. Those are effect sizes. They'll tell us the importance of a clinical trial and really address what the p-value cannot. Let's take a look at the Cohen's d, the differences between drug and placebo in standard deviation units. An effect size of 0.3, yes, you'll notice that, but it's not dramatic. 0.5, yes, we'll notice that. That's generally what we see with the drugs we have on hand to treat our patients. Greater than or equal to 0.6 is very noticeable and more than what we would expect. The Cohen's d for xanomeline trospium combination in addressing the positive and negative syndrome scale total score was 0.65. It was more than expected, so it works. Now, when we think about this, xanomeline is a muscarinic receptor agonist. It doesn't block dopamine D2 receptors, yet it reduces psychosis. Well, that's fascinating because this is the first time that we have in our hands a drug to treat psychosis that doesn't block D2 receptors and works by decreasing dopamine release in the first place and works well. So it works in terms of positive symptoms. There's also an effect on negative symptoms, possibly because the positive symptoms are improved. And in terms of the clinical global impression severity, that's overall marker of a drug working, the effect size, 0.63, means, hey, this works. We can also look at number needed to treat, and what we want to see is an NNT less than 10. The number of patients randomized to drug versus placebo before seeing one extra responder. Placebo is not no treatment, by the way. Placebo in a clinical trial means that someone is not getting the active drug, but they're still being seen frequently and involved in the research process. And if we calculate or define response as a greater than equal to 20% improvement on the positive negative syndrome scale, that's noticeable. The number need treat was 5. That's way less than 10. And greater than equal to 30%, kind of our standard in measuring response in these trials, the NNT was still 5. So still good. And if we go higher and see more robust reductions in the PANSS total score, for greater than or equal to 40%, it's still a single digit. It's 8. It's less than 10. So that's rather unusual. If we go for the gold here and look at the NNT for improvements of at least 50%, doesn't happen often, but it happened twice as often with xanomeline trospium than with placebo. The NNT was 15, so we won't necessarily expect it every day, but it can happen. When we compare these NNTs with other drugs we use to treat schizophrenia, it's either as good as or better than the alternatives. They have NNTs ranging from 4 to 10. So in order to really know if xanomeline trospium is really better than the others, well, we'll really need to do a head-to-head clinical trial to test that. But I can say that it's either as good as or better than what we have. And this is really interesting because this does not work by blocking postsynaptic D2 receptors in the striatum. It works through muscarinic agonism. It's a different way. Now, the tolerability, we need to look at the GI side effects in particular. And when we look at the adverse events occurring in at least 5% of those people randomized to xanomeline trospium versus placebo, nausea occurred in 18.5% for those on XT and about 4% for those on placebo. And that results in a number needed to harm of 7. So we can expect nausea on a regular basis in day-to-day use. We can also expect vomiting, 13.5% for XT versus about 2% for placebo, number needed to harm of 9. So it took 9 patients to be randomized to XT versus placebo before encountering one additional patient with that side effect. But did that cause a problem? Well, if you warn patients about it and manage it, and it does seem to go away, then they remain on the drug. And in the clinical trial, very few patients stopped because of nausea, dyspepsia, or vomiting. The rate of discontinuation, 2.1%, dose reduction, 0.6%. These are low numbers. That's the bottom line there. It took about 50 patients to be randomized to xanomeline trospium versus placebo before having to stop the patient because of nausea, dyspepsia, or vomiting. So in this regard, we can manage this, but we need to know more about it, and I'll talk about it in a moment. Long-term change in the positive negative syndrome scale is observed. Now, this was an open label study, an open label phase of another study, and it shows that patients who are on XT for a longer period of time continue to improve. Patients received placebo at the beginning in the double-blind study and were given XT in the open label portion of the study, and they caught up with their fellow patients who got XT from the beginning. And in the end, everyone was improving slowly over time with PANSS score reductions that are clinically relevant, about 30 points. And in terms of long-term treatment, we look at side effects that may occur, and there's really no surprises here. The duration of nausea, vomiting, it's less than a week. And we can also look at the intensity, generally mild, sometimes moderate. Now, I'm not dismissing it. We have to warn patients about it, and we have to strategize. One way of dealing with that is proactively. If you want to use more trospium, you can do that. It's available generically. You can add it on. You can do something. And actually, when we talk about XT dosing, we can do something that's pretty obvious. I'll talk about that in a moment. So the indication of XT, as FDA approved in September 24, was schizophrenia in adults, and it's the first schizophrenia approval for a muscarinic agonist. The word antipsychotic actually does not appear in the product label, and hence there's no box-bolded warning about elderly demented patients with psychosis. It does block dopamine D2 receptors, so there's no box-bolded warning. And there's no class-level warnings and precautions that include dysphagia and seizures and so on that we find in the antipsychotic drug labels. It's not in the xanomeline trospium drug label because it's not a D2 blocker. Now, the dosing is really very important here, and it was studied in the following way. Patients received 50 milligrams of xanomeline together with 20 milligrams of trospium in a single pill. We'll call that 50-20 BID for 2 days. And then they were given 100 over 20 twice a day for 5 days. Then they went to 125 over 30 BID. And almost everybody went to 125 over 30 BID. Very few patients were stuck at 100 over 20. Now, it turns out that 30 milligrams BID of trospium works better than 20 milligrams BID of trospium in countering pro-cholinergic effects. So getting to 125 over 30, that dose is really important. And going higher more quickly is what I generally recommend. We didn't know this for sure at the beginning when we had this in our hands, and we tended to dose this drug too slowly. And if you do that, you're going to have more GI side effects. I've heard some clinicians go from 50/20 right away to 125/30. I've not done that, but I was told this, and it seemed to work for at least for that clinician. The idea here is you want to get to 125/30. You want to take it on an empty stomach, so 1 hour before a meal or 2 hours after a meal, because trospium is not absorbed with food in the stomach. So what happens if you take it with a meal? Trospium is not absorbed and you'll have more nausea, maybe vomiting. So actually, it's interesting. When you eat, you'll feel worse. So I suggest to patients, make sure you're on an empty stomach or you really may get into a problem here. The product label tells us to test at baseline and during treatment heart rate and liver enzymes and bilirubin. There are contraindications. Can't give it to people with urinary retention because of the trospium. That'll be a problem. You don't give it to moderate or severe hepatic impairment. That's a contraindication. With mild hepatic impairment, it's not recommended, but not a contraindication. You don't want to give it to someone with gastric retention because the trospium would make it worse. You don't want to give it in people with untreated narrow angle glaucoma. And of course, you don't give it to people who are allergic to it. In terms of renal impairment, you don't need to adjust the dose with mild, but you don't want to give it to someone with moderate or severe renal impairment. And remember, bottom line here, taking XT with a meal may increase procholinergic adverse effects because trospium absorption will not occur as it should. Now, word of caution here, anticholinergic agents. Trospium is anticholinergic. We don't want to add to it without realizing that we may increase the anticholinergic burden, increase the risk for urinary retention, increase the risk of constipation, increase the risk of dry mouth. And we need to also be mindful about those anticholinergics that cross the blood-brain barrier. And theoretically, that may interfere with xanomelaine's mechanism of action. So what are some examples of drugs that have anticholinergic activity? Well, clozapine, olanzapine, chlorpromazine, tricyclic antidepressants, diphenhydramine, and of course, benztropine. So we need to be mindful about those drugs. We can anticipate more peripheral side effects and possibly a decrease in the therapeutic effects of xanomeline. Although I say that theoretically because the binding affinities play into this. That's another topic for another presentation. So what's the potential place of XT in our hands in the clinic? Well, those with residual positive symptoms, I would give it a try. Adding it to what their current treatment is sounds logical. Was tested in a double-blind randomized clinical trial, found that there was no advantage there, but at least it was tolerated. So that was done in groups of people, and we treat individual people. So it's something that we do consider. Early switch from olanzapine or risperidone after their hospital discharge to avoid ultimately long-term adverse effects, metabolic, motoric, and so on. Maybe this is useful for those with cognitive dysfunction, but more data is needed. We do know that secondary cognitive and negative symptoms due to postsynaptic D2 blocker treatment can be addressed by not blocking those D2 receptors. We don't block them with xanomeline. Early phase patients may be interested in this drug because we can avoid long-standing anti-dopaminergic effects, as well as the other effects of the other receptor blocking activities of these traditional antipsychotics. May want to think about it for those who have continuing problems with dystonia, akathisia, Parkinsonism. We may think about it for those with prolactin elevation leading to problems. We may think about it for those who have problems with weight gain. We may think about it with those who are easily sedated. Now, xanomeline, I did not mention, is not sedating at all. So if you're looking for something that's not sedating, that fits the bill. Not everyone is going to respond to every drug we give. So I like having these alternatives. And we can address some of these adverse effects by switching the antipsychotic for another second-generation antipsychotic. We can certainly do that. But XT provides another avenue here. Now, the treatment-resistant schizophrenia story has not been solved yet. More data is needed. So the bottom line is XT is different. The mechanism of action is central muscarinic M1 and M4 receptor agonism, thanks to xanomeline, which selectively decreases dopamine in that part of the human striatum responsible for hallucinations and delusions. And by avoiding dopamine D2 receptor blockade, we avoid the collateral damage of drug-induced movement disorders and prolactin elevation. We can also avoid blockade of serotonin, adrenergic, and histamine receptors, and that reduces the risk of sedation, weight gain, and metabolic abnormalities that can be problematic with our traditional treatments. The prescribing information of XT does not contain the class-level warnings and precautions that we find in the traditional antipsychotic drug labels. It has a different array of tolerability concerns that we need to learn to manage, and those are the pro-muscarinic peripheral effects that lead to gastrointestinal issues such as nausea and vomiting. Trospium's peripheral anticholinergic actions can cause constipation and urinary retention, so we want to be careful with trospium, but we're getting more facile with dealing with this trospium dose. The prescribing information for XT also includes recommendations to assess heart rate at baseline and as clinically indicated during treatment, as well as liver enzymes and bilirubin prior to initiating treatment and as clinically indicated. There are adverse events that we commonly think about when treating people with schizophrenia. Weight gain of at least 7%, adverse events of somnolence or sedation, and adverse events of akathisia. Green means go, orange means or yellow means caution, red means no go. So red number needed to harm values are less than 10, and it means that we're going to be expecting to encounter, let's say, weight gain for olanzapine, sedation for lumateperone. With orange, we're going to see this from time to time, including akathisia for cariprazine or lurasidone or risperidone. And basically, we look for drugs that are all green. Aripiprazole is well tolerated, may not work with everybody, so we need alternatives. The xanomeline trospium combination is best in class or best in terms of no difference between drug and placebo and weight gain, and not associated with sedation or somnolence or with akathisia. There are other muscarinic receptor agonists and positive allosteric modulators in development. There's one called emraclidine. The first studies showed NNT of 5 and 4 for improvement from baseline on the PANSS in terms of 20% improvement and 30% improvement, robust decreases in terms of point change. Unfortunately, the subsequent studies yielded negative findings, but it's not gone, and more studies are being planned or in place. There's another one being developed that has some data supporting one of the doses, and that's being pursued. There's other drugs. Keep in mind that muscarinic agonism is not the only way to decrease dopamine release. We can do it through different receptors that we haven't talked about and different channels and so on, and stay tuned. Let's summarize. Human dopaminergic pathways differ from rodents. Muscarinic agonism can decrease the dopaminergic tone where we want to and not where we don't want to. And this is a paradigm shift. So stay tuned for more about xanomeline and other muscarinic receptor modulators.
Thank you, Dr. Citrome, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Breaking the Therapeutic Ceiling in Schizophrenia Care, please follow the link in the show notes. And be sure to subscribe to the DeSera Clinical Education Neuroscience podcast and check back regularly for new episodes covering important topics in neuroscience.